I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
44-year-old female with a history of stage 1B, that is a T2N0, invasive ductal carcinoma of the right breast, ER and PR positive, HER2 negative, and an intermediate risk Oncotype score. And the question I'm just going to direct to Dr. Pegram right off the bat: what systemic therapy, given these young patients that are premenopausal, when you have an intermediate risk Oncotype score, how do you kind of approach these patients, and what would be your preferred treatment for her systemic therapy?
It's really critical to remember that while in the intent to treat populations of the intermediate recurrence score patients in the TAILORx trial did not get a benefit from systemic adjuvant chemotherapy, on further subset analysis, particularly in those women that were under or equal, less than or equal to age 50, there were subsets based on clinical risk that did derive a meaningful clinical benefit from randomization to chemotherapy in the TAILORx trial. In particular, in this case, which she would fit in the category of high clinical risk because she has a tumor that's less than 3 centimeters, but greater than low grade, which is the definition, one of the definitions of low risk that were that did not benefit from the addition of chemo in that setting. But since she's high clinical risk by the TAILORx definition and under age 50, it's expected that she would benefit from systemic adjuvant chemotherapy in absolute terms by about 6.5% to 8.7%, depending on her actual recurrence score number. In the 16 to 20 range, the absolute benefit in clinical high-risk young patients was about 6.5%, and the recurrence score 21 to 25 subset with high clinical risk had an absolute benefit of 8.7% from chemotherapy. So in this case, chemo would be a consideration based on those data.
Can you comment about what would be your preferred regimen in this situation?
You know, since it's a node-negative disease, I would probably be comfortable with a regimen like docetaxel with cyclophosphamide for 4 cycles. I think that would be a adequate treatment for a node-negative patient. I don't think necessarily I would go to the 8-cycle regimens that are anthracycline based. For this case, I'd be comfortable with TC times 4.
Okay, and then would you follow that with a discussion of ovarian suppression and aromatase inhibitor, or would you prefer just something simpler like tamoxifen?
I would. I think, again, it's a balanced discussion. You tell the patients the risks and benefits of each approach. The good thing about ovarian function suppression with aromatase inhibition is it's pretty straightforward to try it. If they can't tolerate it, you'll know right away, usually within the first 4 to 6 weeks. And on that occasion, if they're unable to tolerate that maneuver, then you can easily switch back to tamoxifen for long-term control. So I would bring up the issue of ovarian function suppression in this case and present it as a...
Okay, perfect. So in summary, we would prefer a discussion of adjuvant systemic therapy with docetaxel cyclophosphamide for 4 cycles, followed by optimization of her endocrine therapy with ovarian function suppression and an aromatase inhibitor. And if that wasn't tolerated, then could always be sort of de-escalated, if you will, to tamoxifen.